Well, it's always a pleasure debating with Ed because we all basically you'll see there'll be a degree of agreement here, which was key. But at the same time, what I want to really impress upon you, I think, is that, which we touched on earlier actually, is that truly one size does not fit all. And what I think was so interesting about our French partner's presentation was that as we drill down into that, we see clearly that that is actually the case. And what I hope to convince you is that, as Ed so nicely pointed out, the current US determination trial, which actually Ed is a key partner in, is basically ongoing. I'm pleased to report to you that we're almost at 600 patients enrolled, with another 60, we have to randomize 660, so probably another 100 patients to go. And we will really, we hope, provide a very distinct study in and of itself that will inform US practice, because a lot of this is influenced by what you can offer as salvage. That's extremely important, particularly in the context of survival. And the other piece of it, which Ed very kindly alluded to, is the incredibly important aspect of maintenance, continuous therapy, particularly with an immuno-oncologic, as we now recognize lenalidomide to truly be. So with that in mind, obviously we've seen continued improvement in survival since the introduction of novel agents. And I simply show this as one example. This is from Shaji's paper from a couple of years ago now. And I show it because it's in the older population without transplant as part of it that we've seen new novel agents really make a difference. And I simply bring that point home because what I hope to persuade you is that the relative benefits of each step in improving outcome in myeloma need to be weighed very carefully for the following reasons. On the one hand, we have a very good understanding of disease biology, and we recognize the complexity of this illness, its many different diseases, and it changes tempo and pace within each patient. And obviously, with new treatments, we've been able to establish this as a chronic illness in an increasing proportion of folks. But we also have to be very careful about what we're seeing in terms of long-term effects. And in that same context, I think, therefore, we have to be particularly aware of late toxicities. And are there ways of getting to where we need to be with the immunotherapeutic reset, the reboot that I do believe strongly melphalan and autologous transplant has provided in the past? Can we get there in a different way where, for example, we leave this little particular beast out of the picture? And I think it's very important to recognize this, and I'll show you data to support it, but I'll share with you one of my favorite patients, a wonderful man called Jim Bond, who many of you may know about because he was one of the first patients to really benefit from bortezomib-based therapy and has had a remarkable survivorship. His biggest challenge in his 20-plus year survivorship has been secondary AML, for which he had to undergo an allotransplant. So I think we have to bear this in mind, this key balance of disease control and quality of life. And does, therefore, transplant benefit every eligible patient, and what is its contribution to overall survival? So with that in mind, a little bit of background. I think, obviously, we're moving forward very rapidly in the space of novel therapies, but I just want to share with everyone that the landscape's very busy. And we not only have first generation, but second and now third generation novel agents all making a difference. And we have key platforms like which Ed has had a leading role in, with cellular therapies that are also changing the landscape in a way that's hopefully favorable. Again, in the interest of time, I'll move through this very quickly, but we've already established that triplets up front are establishing a very important platform. They're very important new platforms that are coming through, combining monoclonal antibodies. You know, arguably the CHOP Rituxan of myeloma is on the horizon. It'll be a proteasome inhibitor, an IMiD, a steroid, and presumably daratumumab or elotuzumab or some combination of the same. And we need to bear that in mind as we think to the future. So with that in mind, what is therefore the role, and how should we think about transplant? Should it be used in everybody? And if so, for who? And very importantly, when? And I think in the US, in the context of US practice, we're blessed with the resources to be able to collect and store and kind of wait and see. And there are definitely patients in my practice who may not wish to participate in the randomized study, who would like to keep their stem cell option in reserve because they have very specific lifestyle choices that they have to make. For example, career changes, graduations, family events, and so on. Is it reasonable for those patients to wait? And I would argue in US practice it probably is. And let me explain why. Well, first of all, we have retrospective data, which I think many of you are familiar with. This is one representative example from Shaji Kumar and the group at Mayo, showing actually no difference in survival for delayed versus early in their experience. But of course, the caveat here is, on the one hand, this is primarily IMiD-based, and on the other hand, of course, this is retrospective and reflects Mayo practice. It's not prospective. Ed very nicely showed you the very compelling data from Antonio, and I just want to emphasize the point here. This is without, of course, a proteasome inhibitor on the one hand, and on the other hand, this represents practice in Italy. What's available in the salvage setting becomes very relevant. And of course, we have strong PFS benefit. Ed touched on this beautifully before. What is interesting, and why I want to bring it out, is that LEN maintenance mattered. In this study, if you were on LEN maintenance until progression, you did the best. And we'll come back to why that matters in a moment. Already touched on the fact that you need a proteasome inhibitor, you need your Army, Navy, and Air Force, arguably your Coast Guard and your Marines, and in that context, bortezomib matters. You can't leave it out. If you do, you have an inferior outcome. Now, what's the platform behind triplet therapies, and what informed us in terms of the current trial that Ed very kindly outlined? Well, it was, of course, the initial experience with RVD, which we published now some years ago, but we did a landmark analysis in which she showed no difference between transplant and not in the context of a multi-center US trial using the RVD platform. This work was taken further by the group at Emory, led by actually Saga Loniel and his partner Dr. Nuka, and what they showed very nicely is that in fact in a very large experience, if you had late versus early, survivorship actually was not different. Now we have to be a bit careful here because this obviously was not prospective, but this was certainly provocative. Hence the platform for this study. And I think what's so important about this trial, and I want to sort of really acknowledge actually in particular Ed, because he was instrumental in us getting this into the CTN, and with the partnership of the CTN and the Alliance, and also the Determination Study Group as it's called, we now have almost 60 centres, and we have an enrolment that now can actually match our French partners. And it's been a true privilege to be part of that group, and we hope this group will actually be a platform for what we call Determination 2, which will be the next set of studies that test this question, because the landscape's changing very quickly. The critical point for the US study is that lenalidomide continues until progression, and very importantly, our patients in the US, of course, have access to US salvage strategies, the promptness of those being available in the community being a relevant point, as well as, of course, in the context of clinical trials. Now, a couple of points to make. I do want to acknowledge my partner and colleague, Dr. Nikhil Munshi, with Hervé Ave-Loiseau, who are looking very comprehensively at the MRD piece that Ed touched on, and they're also looking at a whole array of genotypic and phenotypic characteristics of disease so we can truly tailor therapy. Ed showed this very nicely. I won't dwell on it, but I want to make a point. Basically, this is an 8.8-month improvement, to be precise. Now remember this, because if you actually think about it, what was the difference in PFS provided by lenalidomide until progression? 2.5 years. Not just in one trial, the CLGB 100-104, but also in the French study. So lenalidomide maintenance buys you 2.5 years, transplant gets you 8 months. Let's bear that in mind as we go forward. If you think about the response rates, Ed touched on this beautifully, quite so, and indeed there is a difference in MRD negativity in favor of high-dose therapy, completely understood. The difference, to me anyway, I was expecting a big difference. Actually, it was a little closer than I thought it might be, and I think that's a relevant point. What's also very relevant is there's no difference in survival, and actually if you look at the hazard ratio and the confidence intervals, actually the non-transplant arm is doing quite interestingly well. These are the best results, by the way, ever seen in this setting in a prospective trial in the autologous setting anywhere. So both arms are doing very well. What's a bit sobering is this, and I bring it to your attention because it's really quite relevant as we think to the future. Obviously, transplant generally is a very safe procedure, so these numbers are very low, which is good. But what caught me was this. This is early data in this setting. As you can see, whilst the numbers are small, the actuarial difference is quite striking in a percentage term, and I would just suggest we watch this space. And I speak to it because one of my own patients, who was assigned to Arm B of this trial, was in VGPR as she went into transplant. She tolerated her transplant relatively well, but she had poor engraftment, and I had no clue a priori that this would be a problem. Her stem cell yield prior to entry into the transplant was excellent, but post-melphalan at day plus 50, her platelet count hovered around 50,000. By 18 months later, she was dead of aplasia and emerging secondary AML. She went into the transplant in VGPR. Lovely woman, her family are incredibly understanding, but at the same time, that's someone who shouldn't have gone to transplant for obvious reasons. How can we fence that patient off in the future and protect her from an outcome as bad as that? So it's a very relevant point. In addition, if you look at the MRD data that Ed showed, there is one point that I can make, and in fairness to Ed, he's not aware of this, I am, because obviously we're part of the same trial group with our French partners. But what is very relevant is that when we looked at when MRD occurred, it continued to improve across lenalidomide maintenance for 1 year. When lenalidomide maintenance stopped at 1 year, in both arms, things started to happen. And also there was a continuum of MRD negativity emerging across maintenance. So the question around what MRD means, particularly in the face of continuous therapy with lenalidomide, is essentially unanswered at this point. And that's the critical nature of the US trial. And I show this slide simply to emphasize the point that in the context of lenalidomide maintenance, with the study led by my colleague Phil McCarthy in the Alliance, we see a survival benefit that's growing over time. The French study, they stopped lenalidomide maintenance essentially at 2 years. And in that context, whilst they have a PFS difference, Michel has not shown a survival benefit, and I think that is relevant. So I'll move relatively quickly through the rest of this because I hope it just reinforces the point. But this is a study that perhaps is underappreciated. It's published by John Careth, who's in our group and part of the CTN, a really top-class transplant physician. And John showed here that, in fact, if you look in meta-analysis, the impact of successful salvage is the most important determination of survival. And so that's why in US practice, I would argue, this really matters, because the quality of US salvage therapy, we know this from the IMWG work, is the best in the world. So in that context, in the context of US practice, I would argue certainly autologous transplant is an important option for younger patients. But should every younger patient have an early transplant versus late? I really don't know, and I think the trials will answer that question. How do I support the salvage strategy statement? Summarized here, and in the interest of time, I'll move through it very quickly. We have phenomenal combos, which Bob and I will talk about in a minute. Carfilzomib-based therapy, I've already touched on how promising I think that is. Pomalidomide-based therapy, etc., etc. And of course, now the advent of the antibodies. Very quickly, these are the takeaways from the ASH meeting that just illustrate the point that the future is very bright. We have HDACs, IMiDs, BTK inhibition, new cytotoxics that are less toxic perhaps going forward, and very importantly, very exciting immune therapies. Again, I'll move through these very, very fast because I don't want to repeat them because we're going to come across them later when we talk about relapsed refractory disease, but they just give you an idea of how exciting the future really is in terms of these various combinations. And as we go into the future and look at outcomes like, for example, the introduction of checkpoint inhibitors and monoclonal antibodies, we're really looking at a very exciting future. So this is my summary. Novel agent conditions have really improved things, and I completely agree with that. Depth of response matters. How you get there may be actually very, very important for long-term toxicities. So therefore, should we think about stem cell transplant in everyone? I would argue not, and participation in clinical trials is essential. At ASH, we had a bonanza of new and exciting areas. And so on that note, I would simply conclude that one size therefore does not fit all. Stem cell transplant is and always will remain an option for younger patients, but I would argue not a requirement, and participation in randomized trials is essential. Thank you for your attention.